welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Fred Trotter. Fred is a healthcare data journalist and author. He's a founder of CareSet Systems and the DocGraph Journal, a technical blogger for O'Reilly Radar, and co-author of the first health IT O'Reilly book, Hacking Healthcare. Fred won the 2016 Healthcare Data Liberator Award for his work opening up significant healthcare data sets for broader use. He is an alum of several successful technical startups, and you've seen his commentary and data journalism featured online and in print in a variety of technology, healthcare, and mainstream media outlets. You can find Fred online at fredtrotter.com and on Twitter at fredtrotter. Welcome, Fred, and thanks for joining us.
It's really fun to finally be on your podcast.
First question, Fred, what does it mean to be a healthcare data journalist? Well, what do you do?
Well,
Can you share some of your scoops?
Well, so the first question is very difficult to answer. I ask myself that every day. I'm not exactly sure what a healthcare data journalist does, but I can tell you very clearly what I do all the time, so that's much easier. What I tend to do is to try to use clever means, usually things like FOIA requests or other kinds of collaborations with governments, and sometimes private organizations to try to get previously covered over healthcare data sets available to the public out of the world of the useless and into the world of the useful. And I regard data sets that are trapped inside private organizations or government organizations that, usually for privacy concerns and sometimes for other reasons don't benefit the public at all, but would really be beneficial if some slice of them were released. You can go to CareSet Labs is how we usually release data sets now and get some of the data sets that I release directly to the public. But most benefits that my work does are indirect. So through CareSet, we actually sell commercial data to people who want to use the data for business purposes. And then I also work with the Association of Healthcare Journalists or members of the association and ProPublica, and who have made use of data sets that we release, and sometimes even talk to me about their use of the data sets that we release and collaborate with me. There's actually a lot of organizations, but those few have actually worked with us to get data and to make them more useful. Practically on a day-to-day basis, it means I write a lot of FOIA requests. I spend a lot of time collaborating with agencies. I spend a lot on the phone with government people. So we have definitely a huge kind of a government relations strategy that we're working for. And governments want people like us to do what we're doing, and I think it's the relationship that I have is a lot less contentious than I think a typical journalist, because in some cases I'm asking the government to kind of understand things about itself that it never has before. So for one of the interesting things we had when the first data set that we got out of the federal government is actually the name of our journalism efforts, is the DocGraph data set. And what was really interesting is that the FTC came and asked us for that data. And it was easier for them to get data from us about what was happening inside CMS than it was for them to go to get CMS data themselves, because it's red tape from one.
Sounds crazy, but I'm sure it's true.
Yeah, it's actually just slightly easier. So, but that's the kind of thing that we help with, and of course I am very honored that I was on, not last year but the year before last with Health Data Liberator of the Year award, and a lot of people I really respect have won that award before, and of course since then as well, and so the notion that healthcare data should benefit people generally. Even though I kind of, in terms of plumbing, I'm right in the middle, right? So I'm not the person who has the data, and I'm also not the person who delivers that end value that the data will have ultimately to the patient. That's pretty important to me, and it's become a bigger and bigger part of what I do.
Can you give us an example of how you deliver value, or how a customer of yours might deliver value out of the data that you're able to pull together?
Well, so one thing that a great example of that is people. Let's say you have the kind of people who hire us are people who, for whatever reason, have some innovation they want to bring to the healthcare marketplace, and they don't know precisely how to do it, right? And when I say precisely, I mean like what doctor do you call on, what CEO of what hospital is worth talking to, should you market in Wyoming first, or should you market in Alabama first? Very specific questions are the answer. But the wonderful thing about what we do is, generally the model is you're trying to steal huge healthcare costs in the future and replace them with smaller costs in the present. The people talk about the healthcare costs out of control, and one of the few things that we have to agree with CMS that has kind of, most of the stuff we agree to are to get data, the kind of data access that we have, which has become very profound. Medicare provides us with CMS provides us with very, very profound access to both Medicare and Medicaid data. Most of the things they have you sign have to do with, you're going to follow these security protocols. One of the kind of existential things is that you have this obligation not to, defraud the government, because that's just following the laws, but also, kind of generally do things that are bad for the program. So I kind of feel protective towards Medicare and Medicaid as programs, and want to ensure, and so far it's been easy to ensure that all kind of doing proper things. But going back, you can take a cost like, let's say you invent some test or some procedure costs $500. And if you get that test or procedure 5 years from now, you won't get one of these mass expensive things like cancer or heart disease or diabetes, or, there's these kind of huge looming monsters that if you get these diseases, it's in terms of your quality of life and also the expense of the system, it's actually cheaper and easier on everybody if you just hit by a bus. These kind of nasty, expensive diseases that are both hard on people and hard on our system. If you can spend $500 or $1,000, even $5,000 this year, and then avoid that future cost in 5 years, that's a bargain on everybody's calculus, right? The payers like that. Medicare likes that. The patient loves that, right? Because they've experienced a dramatic quality of life, and they might not even know. You might just resent that $4,000 or $5,000 expense that you had to share with your insurance company this year. But if you knew that it could avoid you having cancer or avoid serious heart disease or some other massive complication 5 years from now, you would do it. Of course you would do it. So in some cases, I think that the people being happy and grateful is not always the same thing as them being well served. But nonetheless, the idea is basically to steal money from the future and put it in, kind of present year's budget, which does increase costs, but in the short term anyways. But in the long term, it saves everybody money and makes everybody happy in the program. That's what preventative care sounds like. So we've always talked about how, the notion of healthcare homes and these kinds of things. But ultimately, you're deciding what you want to pay for when, and you're choosing what to buy. And in general, that makes for better healthcare. That's the kind of people who pay us. We also work with, organizations that are just interested in understanding how things work, journalists, other government agencies, and they're interested in, and I find this kind of stuff really fascinating too, is the kind of ebb and flow of how things work. So when the data set we first released was this data set that showed how providers share patients in a given year in the Medicare system. And you could see things, and then someone from our community took that data and put it onto a map, and then just drew lines between the different locations. And you could actually see snowbirds coming down from New York to Florida in the winter, and you could see how, in the western states, there's kind of hubs where everybody's driving a long way to get to the hub of activity, and you could see how our healthcare system delivery works. And all it was just lines on a map between providers who were sharing patients. So some people are wanting to sell things who work with me, who pay me usually, and then the people who don't fit in directly are the people who are interested in modeling the healthcare system. Usually, those are healthcare system researchers of one kind or another. Sometimes bankers or government workers or just students. And then sometimes just hackers, people who, come to our website and say, oh, I want to download a massive data set. It's interesting. I mean, if you're a computer scientist, the data set that we released, I believe, and it's actually, they've started to include it in books about, graph theory, because it's a graph data set, which is to say a data set with nodes and edges. And I believe, I'm not sure about this, but I believe that it is still the largest real named data set of that structure, right? Because if you want to look at the structure of Facebook or Twitter, those are graph data sets as well. You can go and ask them for some data and they'll give you a lot of data, but it's a teaspoon of what the data that they actually have, right? Very, very small subset. But our data set was released in its entirety and it used real names, right? So for the first time, you could see how different real entities in the world were connected to each other over time. And it was a massive data set. And they've started to study it when they study how to just work with graphs, because it's one of the very few people graphs that's completely open. The web and Wikipedia being, of course, great examples of graphs that are open that are websites. So that's kind of the rant about the reason why I think it's interesting to get up in the morning.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Fred Trotter. He started to talk about the amount of data, the volume of data that's included in this graph, and that's, for me, a segue into something else that I wanted to touch on here, which is questions around cybersecurity in healthcare. There's so much data online, and there's so much that we need to be careful about in terms of real name data, in terms of real data that's out there. In 2017, you served on the Federal Healthcare Industry Cybersecurity Task Force and dove into these waters, and the task force issued a report in mid-2017. I'm curious if you could share with us something that you learned from that experience and what the rest of us should be learning from that experience and from that report.
It's interesting because when you get onto a task force like this, it's really a meeting of the minds in a fascinating way. And of course, I was there and invited because I have a background in information security and cybersecurity. I worked for the Air Force Information Warfare, and then also VeriSign before getting into health IT. And then, of course, now I have healthcare IT experience. And I was actually invited as a kind of a patient advocate, and you kind of advocate for patient rights and patient access to data and all this kind of stuff. And would you be interested in going on there? We try to say yes, but we sign up in a very similar way. And I think my application said, if you can find, I'm willing to do this, I'm qualified to do this, but if you can find somebody else, please do. And they took that kind of despondent sign up. And really the people on the task force were these heavyweight people, and talking about the experience, that you get all these people in the room with very different slices of the picture. Of course, there's Terry Rice, who's the CISO for Merck. Emery is the Chief Information Security Officer for CMS, and he was the kind of government leader. And then you have these heavyweights who are in this group. And they all come together, and they're all very deep into what they know. And I was surprised that I kind of knew. I ended up being kind of a voice for health IT generally, because there were a lot of healthcare cybersecurity experts, but they really didn't understand how EHRs work and how PHRs work, and what had been doing to try to change things about the way health IT worked. And I think a concern overall was, we've been fighting for years for patients to have the same kind of access to information in healthcare as they do in banking and everything else. Great strides over the last, say, 10 years, 5 years, especially the last 5 years. But, for the last 10, really, we've been making strides. The line used to be that the reason an EHR, because it was good software, it was well designed, you were following cybersecurity rules. It was just that it was so far behind the firewall of these organizations that it just couldn't be, realistically hacked. It wasn't a target because it was just so deep in these organizations, and it was treated like a proprietary secret. Well, now with ways to get in that didn't exist 5 years ago. So, I ended up spending a lot of time defending decisions that the industry had made in terms of EHRs, and I knew I was going to have to defend PHRs because that's what I thought my role was. But I just general, like, here's the reason why we do things the way we do things in health IT. And I don't always agree with the reasons why we do things in health IT. So I was very frequently kind of taking a double apology role where I say, this is the way we do it, and this is the reason, and I know that sucks, but it's nonetheless the way we do it. And here's why, and I can't, and I disagree with this, but I have not been able to convince the industry to do anything different. But then you hear about kind of the you have this kind of stage of these meetings where it's like a group confessional, but rather than confessing your sins, you're confessing your fears, and you're confessing the thing that you're most afraid of, right? And if you take the fears from a cybersecurity manufacturer and the fears of a cybersecurity expert like Josh Corman, is absolutely on the cutting edge of cybersecurity writ large, and then you combine those with the fears of somebody who's a chief of information at a hospital, and then the government fears. It's a lot of fears. And what was really disturbing about the fears is that we kind of did this doesn't happen. I really hope that doesn't happen. We had those conversations very early on and it's kind of good. We had private sessions. It was good that we had public sessions and private sessions. It was good that we had the private sections, because in the private sections, it was almost a map of how you destroy the country by using cybersecurity to go hack healthcare systems. It was really kind of a nuclear bomb level cyber attacks that we knew how to do collectively as a group that we were discussing. And what's interesting is that although thankfully we didn't have the all of once, we didn't have a nuclear level event, we did have probably almost every type of that we had going into those meetings at the early part actually happened in the year following. It's like, so somebody says, we're really concerned about this notion that maybe people are going to really pick up on the ransomware. Sure enough, that's been picking up, and that was happening while we were on the board. It's happened since then, and ransomware has become more and more of a problem, especially because it's so ironic, because ransomware is one of these things where the interests are just so vastly skewed. Like the National Health System in England, I think it cost them into the billions of pounds the last, I can't remember if it was billions or hundreds of millions, some very large number, and the total amount that could have been taken, like assuming they had given them the money, they try not to, right, because they're a government agency, they don't want to fund people doing ransomware, was something like $10,000 or $20,000 at the time. And just an insane amount of destruction from someone who wants to make very low dollars and actually makes very low dollars doing it, but is willing to destroy it by releasing these kind of ransomware things. So that happened, right? We were concerned about that, and that happened. We were super concerned about the notion that someone would start to manipulate stock prices by releasing cybersecurity vulnerabilities in an unresponsible way. So the way you're supposed to release a cybersecurity vulnerability is, like if I find a problem with Microsoft systems, I contact Microsoft and I say, hey guys, you got an issue? Here it is. Here's how to replicate it. And they say, okay, that's a big deal. Thank you. And they give me credit, and then they release that information publicly. We decide, well, it's going to take a month to fix. They fix it. They release the fix. And then they announce that there was a problem. That's the way it's supposed to work. And there's problems on it took years for that kind of basic workflow to be worked out in general software. And healthcare is not used to that, right? So if you contact a device manufacturer and say, I found a vulnerability in your device, and they do not have the sense to have good, even-tempered lawyers like David Harlow on their staff, then they can react very badly and say, well, look, if you say about this public, we'll sue you. You send a cease and desist letter, all those kind of things. And that puts a security researcher in a real uncomfortable position, because they have an ethical obligation to ultimately reveal to the public that there's a problem, because someone else might find that problem. And unlike the security researcher, they're just going to hack 1 million medical devices or whatever. And so the industry is still learning. But one of the things we're concerned about is maybe somebody was going to release the fact that a medical device was messed up and do it in a way that made a big news splash to lower the price of a stock after they've shorted the stock. And indeed, that's happened too. So that happened while we were on the in the group. Cybersecurity is really complicated. It's really hard. It was humbling to hear all these different perspectives just in the group. But then not only did we have the people in the group, we had a bunch of people come and speak to the group from various industry information. Sometimes that was I don't think I'm supposed to swear on this. I think this is a PG rated thing, but sometimes it was not legitimate. But other times it was, and I learned a lot, and it was a very, very good experience. It is disheartening though, because I think in any other political environment, the report that we had released would have probably been a bombshell. It would have probably been like, hey, we really need to do something different. This is a real problem. It would have been front page news, if not on the New York Times, then at least the federal Federalist papers, or one of the wonderful rags that you and I probably follow about what's happening in the government. It would have been picked up and followed. But I think there's been so much drama lately, and that I think politics has so far outshone policy that it's really hard to get much attention for that work. I am quite proud of it.
From my perspective, it's a report, it's good work, but it's sitting on a shelf somewhere. And,
yeah, precisely.
Wish that
the one thing that we did
implemented in some way.
Well, and the one thing that I think we put a bunch of effort into, and I hope this will pay off, or actually I hope this won't pay off. That's the right way to say it. I hope it will pay off if it's needed, and I hope it's not needed. But what we tried to do is put a lot of energy into, like, if shit really hits the fan, this is what you should do. And there's whole sections of it, that are kind of like, we know that you're going to probably just put this on a shelf. But if you're ever in a position where, things are really gotten bad and you want to have a playbook, we can't spend too much time on it, but here's the top 10 things you should do, right? Or something like that. Mm-hmm. We put a lot of energy into trying to make it useful in that manner. I hope that has value in terms of, I hope the quality of it was good, and I hope it had some of the right answers. But again, I really do hope that I hope that there's a policy will to come back and look at it again when there's less drama. If anyone is discussing impeachment seriously, it's real hard to discuss whether or not, vulnerability disclosure policies within medical device companies is appropriate, right? And it's just like, those are two orders of magnitude less noise, but important.
Right. Absolutely important. I'm going to ask you one of my favorite questions, which is, if you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or would expect that has changed drastically?
I hope there is a way to digitally contact a doctor. I hope I can just open my computer and go to some kind of a system that is as easy as email and is a way to digitally send a message to an arbitrary doctor that does not involve fax machines. And that's really the only thing that I want, that I think is definitely doable in 5 years. But it's like, it might not happen even then, right? I think we might be on faxes for another 7 years. So if I could get rid of them in 5, that'd be a happy day for me.
That sounds good. What do you think would have to be in place to undergird that kind of connection with physicians?
It's funny. I was somewhat involved with Biden's Cancer Moonshot stuff. We released a data set for that, and I got to go to his meeting. And of course, it's really amazing to see people kind of coming together for something that big. And I was asked the same question. And it's interesting because people always assume that's a how question. It's a technical problem. Almost all the problems associated with health IT interoperability now are political issues. The technical problems have all been solved, right? So there's the Argonaut project, that's an API. There's the Direct project, which is an email interface. All of those things work. They work relatively well. They're not great. They're not brilliant. And they're certainly rough around the edges. But they all work, and they're all decidedly better than what was available even a year ago or 2 years ago, much less 10. The roadblocks are that people really don't want to share data. And the reason you don't want to share a patient's healthcare record is because you share a patient's healthcare record, you share a patient, and the patient, unfortunately, in the American healthcare system is regarded as an asset. If you have a patient, that is it's the same thing as having a grove of oranges or a silver mine, right? So, having 1,000 patients, you want to do everything you can to not have those 1,000 patients. Unfortunately, it's one of those Mexican standoff things where you're never going to get Mayo Clinic to share data with Cleveland Clinic unless they've both been told to, and the whole industry is doing it all at once. I do think there's promising political progress. I think in some senses, the reason Argonaut is significant is that it is a political movement, and Epic is on board with it. That's the same thing with the Direct project. Epic supported the Direct project too. You can't have the one massive vendor as a holdout politically to whatever you're trying to do and then presume it's going to succeed.
Well, thanks for talking with us today. I appreciate it, Fred.
I know it's supposed to be like more of a conversation where you say something and I say something, but when you ask me big questions like that, I just kind of go off. So I hope that was interesting
right.
to your
We've got to address the big questions, and it's certainly interesting to hear your perspective on all of this. You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.